Next speaker up is Paul Anderson, who probably does the most number of urethroplasties in the UK per surgeon. He works near Birmingham and Dudley, and also at the Centre of Defence Medicine at Birmingham QE. Paul is going to talk about urethral reconstruction.
Good morning. Thanks for asking me to come and talk. I lived in Manchester for 12 years, and the only reason I left was because I couldn't get on the Manchester training rotation. Right. So, Duncan told me a while ago he's going to ask me to give this. So I did something very unusual for me. I actually went to the big 4 meetings for sort of GRS people, starting with Prof. Mundy and Daniel Hendricks' masterclass, which is excellent, SIU in Glasgow, EAU in Madrid, and AUA in New Orleans. And one thing I'd say about going to meetings is, it's a lot of fun, it's very expensive, it's a bit lonely, and it's always the same old faces, actually. And my impression was that actually there's nothing new in urethral reconstruction, and it would be a very short talk indeed. But I spoke to Duncan about this, and he said, well, we'll go back a year, go back more than a year. So I don't think much has happened in the past 12 months, but I'll talk to you about what's sort of trending and things that are changing over the past couple of years. And I got most of my information actually from talking to people at the posters, and also the big discussions that go on after, all the abstract and poster presentations. So this is what this is based on, not in the literature, but going around and talking to people and finding out what's going on. And this is very much the hot topic in urethroplasty. It's all about vascular preservation. Do not sever that blood supply that runs up and down the urethra. I'd like to point out straight away that anyone who does grafting procedures for urethral structure, you are not disrupting that blood supply. That's not what I'm talking about. I'm talking about anastomotic when it's absolutely transected. So, with vascular preservation, there is the NT-ABU, which has been popularised by University College Hospital London. But actually, this isn't new. These pictures are taken from the BJUI Surgical Atlas 2011. And what it's showing you here is that you do the whole of the operation from above the urethra. Okay, so you can see just there, you're operating straight down onto the urethra, and this lowest part is never disrupted. So you're only affecting the blood supply in that area just there. The stricture is cut out and sewn together, and then it's sewn up with an opposite spatulation. But the issue is the vascular supply is not affected. So you've got NT-ABU, and you've also got the so-called vessel-preserving anastomotic bulbar urethroplasty, which is a bit more tricky. And in this, you have to identify the vessels that are running in this area here. I don't know if they're projecting well. I don't believe that they are. But there's some vessels which are, slooped here with a vascular loop in the area of the proximal bulb. And the whole operation, the anastomosis, is done preserving those bulbar arteries running forward. Okay, and then the anastomosis is done. This is taken from a BJUI Surgical Atlas 2008 by Jerry Jordan. So again, this isn't new. The only thing that's really new that's happening is people are trying to push the boundaries and do this for posterior urethroplasties now. So when you have a road traffic accident victim with his pelvic fracture and you're doing a bulboprostatic anastomotic urethroplasty, people are trying to preserve an artery on the one side. I think it's a bit of a nonsense, and it's simply because if you have a bad RTA, a bad pelvic fracture, the arteries have gone anyway. So if the arteries have survived, you're doing a fairly straightforward BPA, and the outcome from that is 95% plus success. However, as a technical exercise, I think it's very nice if you can preserve the artery on the one side. Clearly you can't preserve it on both sides because it sits in your way. You have to flip the urethra to one side. So I would say that is new. People presenting data of vessel-sparing posterior urethroplasties. The other thing, which again I don't think is particularly new, but people are pushing more now, is single-stage tubes are coming back and getting longer. Now, what I mean by that is that the full circumference of the urethra is replaced in one single operation. Now, single-stage tubes very much went out of fashion because they've got the higher complication rates and the higher failure rates. But if we look at, lichen sclerosis BXO, you normally do 2 operations, and these are slides I used last year when I was lecturing, in Liverpool. So there's your first stage operation. I know I'm talking to people that know about urethroplasty. But on a hyperspadias repair, you could, for instance, you open that area, take out the diseased urethra, put a graft in, and put your tie-over dressing in. 6 months later, maybe 3 months later, You then close everything up again, close in about 4 different layers, and that's your 2 stages. However, it is possible to do your first stage and immediately go straight into a second stage. Now, I've been doing this for intragranular strictures ever since I began, which is about 9 years ago now, because my predecessor, Mr. Bracker, always did this. And this is because the glands is so thick and spongy, the graft is supported all the way around. So again, I don't think this is anything new. What is new is that people are now starting to use this at the sort of subcoronal watershed and taking that tube down further. And this abstract here, which was put into the EAU, and then exactly the same abstract, word perfect, was put into the AUA. That's a really common thing I've noticed. I've never really gone to EAU and AUA in 1 year, but the abstracts are just absolutely word perfect copied. So they looked at 53 patients over 6 years, compared it to 71 patients over the same period at a 2-stage, and they got similar outcomes. And their mean stricture length was 4 centimetres. So I think it's pushing the boundaries of what can be done as a single-stage tube. And maybe I'll start doing that because it would reduce waiting lists. You just do 1 operation instead of 2. I don't regard this as reconstruction, hacking a bladder neck that's scarred up. But this is a very big topic now. Bladder neck contracture, more properly called vesico-urethral anastomosis stenosis after radical prostatectomy, is taking up a significant, proportion of all the abstracts, 25%, 30%, especially in America. So there are absolutely loads of abstracts, and they're doing all sorts of things. They're doing cold knife, they're doing bipolar, they're doing conventional, they're injecting steroid, they're injecting mitomycin C. But what's interesting is they are getting up to sort of 50 to 80% success, which does mean with the vast number of bladder neck contractures out there, most of them are being spared a redo vesico-urethral anastomosis, which some of you will have seen Professor Mundy and Daniela Andrick presenting at this meeting in previous years. So again, that's not new, but that is a hell of an operation and quite brutal. And if you can get away with doing something like this, it's clearly much better for the patient. So this is occupying a lot of abstract space for the urethroplasty sessions, but I don't regard it as reconstruction. Urethroplasty improves your sex life. I was quite excited about this, but it doesn't refer to the surgeon, it refers to the patient. And it's when you use a ventral graft. So this is when you are actually doing a sort of minimum disruption. So for those of you that do urethroplasty out there, when you're cutting straight through the midline, all the way through to your stricture, minimal dissection. Enzo Parmentieri, he's from Italy, and he came over and trained with Bracker, partly when I was a registrar for Ivor Bracker. So I know exactly how he does this operation, the same way that I do it. And what was very good about this paper is something which I've always suspected, and that's that, a good urethroplasty completely improves your sex life. I mean, you can argue the ins and outs of whether an anastomotic gives you glands numbness and lack of glands engorgement, which I think it does. But, a ventral graft, and these people are back to sex very quickly, and they're much happier. And that was at the Madrid EAU. I don't need to cover this anymore. Again, this is a slide from Steve Payne, just talking about the urethroplasty audit database, which has been an immense amount of work and very, very impressive. And there's going to be individual surgeons, and it's going to be accessible to patients. But Vijay has already just been through this. And finally, the open trial, which Rob Pickard just updated us on at about 10 to 9 in the Baggers meeting just before, and actually it's hitting its targets. So it is recruiting just above what is required. And there's a very impressive number of sites with full approval now, 53, lots of screening, and you can see the leader table. That's it. Thank you very much.
Thanks, Paul. That's a great overview. Are there any questions regarding urethral reconstruction from the floor? Paul, this sort of pushing the boundaries with single-stage distal tubes, why bother?
I think it's because you can. I have had private patients that have specifically come to see me to have a single stage done. So I think patients don't want to have 2 operations. They don't want to live with a proximal ureterostomy. I think you can do them. Of course you can technically do them. It's just that the outcomes historically were worse. And when you think about the thinness of the corpus spongiosum of the ventral penile urethra, it does not offer the same support as the glands at all. So there's a big difference as you drop down below the glands. So I think the drive is to give people, one operation. If the outcomes are similar, and they were for UCH, why not do it? But I would be hesitant because of that blood watershed area in the subcoronal bit.
That's usually we get fistula and restricting, isn't it? Okay. Any questions from the floor, please? If you've got any burning questions, okay.